Hi, this is Brian Kim. I'm going to share with you case number 22 in the best way to do cataract surgery series. This is a 1+ dense lens with a medium pupil, and this is a completely unedited case. And I wanted to show you from start to finish my standard technique, but also, again, looking at a smaller size pupil, how to be able to disassemble the lens and prolapse the pieces out of the bag efficiently and without much trouble. And this, in my mind, is the best way to do cataract surgery, because by using the chopper and leveraging mechanical forces, by pulling pieces out of the bag and not relying on using ultrasonic energy or vacuum to pull pieces out of the bag, this is the most powerful and most efficient way to prolapse lens pieces out of the bag. And in order to do this, you have to be comfortable working in the capsular fornix space. You can tell that this is a medium-ish pupil. I'm using my corneal mark to help me center and size my rhexis. I'm going to use my diamond blade to make my paracenteses incisions. You want to make sure they're flat to the iris plane, making sure you have a nice shelf. And as long as you make sure you're parallel to the iris plane and you get a nice shelf as you make your corneal incision, this will help ensure that these incisions will seal. I like to hydrate the sides and the roof of the incision. I go ahead and inject my intracameral lidocaine, and then I'm injecting intracameral epinephrine, and I'm going around on top of the iris as well as under the iris, and I'm very gently pulsing the epinephrine to help stabilize the pupil. And then I'm injecting my dispersive viscoelastic. This helps also to visco-dissect the pupil. You can see the pupil has gotten bigger, but unfortunately it doesn't always stay this big. The pupil is actually big because of the raised intraocular pressure. So I do my triplanar corneal incision using my cannula to hold the eye. I make a vertical groove and then go through the groove and then tunnel. You can see my cannula slipped out and then I slipped it back in. And then I dove into the eye, and this is my triplanar corneal incision. I do my puncture style capsulorhexis. I puncture down towards the subincisional space, and you can see with the teeth closed. I try to inch the flap towards me because as I pull down, you can see that the cut in the capsule didn't come straight towards me. It went slightly left of me, and that's why I did that little bit of that inching technique with the teeth together. I was kind of gently pulling the capsule towards me so that I can grab and create a flap. As you can see, I'm going circumferentially, grabbing and re-grabbing, trying to follow the corneal marks to help me center and size my rhexis, and also to minimize any pressure on the incision so I can make sure I don't have any viscoelastic egress. So I begin my capsular fornix hydrodissection. I place the cannula out to the equator contra-incisionally. I go flat and underneath the anterior capsule. I get into the capsular fornix, turn the cannula tip down 90 degrees, and I get a nice fluid wave. I decompress to the left side, and then I spin to the right side. I'm irrigating the cornea first to flush the tubing, and then I lift my incision with my chopper and then go in the eye with irrigation off to minimize Descemet's trauma. I begin my double chop maneuver. I remove the surface epinuclear material, place the chopper out underneath the epinuclear material, out to the equator, turn the phaco tip vertically, crush the lens material. That's the double chop maneuver. Place the chopper out to the contralateral equator, hold the chopper centrally, meeting the phaco tip in the middle, and this crushes the right heminucleus. Now you have 3 separate pieces. I place the chopper out to the equator again, crush the lens pieces between the chopper and phaco tip, and emulsifying the lens pieces. I prolapse the second quadrant out of the bag using the chopper, and then I'm using mechanical fracturing forces to crush the lens pieces into smaller pieces. I rotate the second heminucleus in front of me, place the chopper out of the equator, crush the girth of the lens material between the chopper and the phaco tip. I'm crushing the third quadrant into smaller pieces, using the chopper and phaco tip to crush the lens pieces into smaller pieces, and then I'm using high vacuum to emulsify the lens piece. I'm crushing the fourth and last quadrant, placing the chopper out of the equator, and then crushing the lens pieces. I'm using mechanical forces to crush the lens pieces into smaller pieces, and I'm able to evacuate the lens piece. Again, not using any ultrasonic energy in this case, just using the high vacuum to remove the lens pieces. Again, I'm able to efficiently remove the lens pieces without good visibility into the periphery of the lens, without being able to visualize into the periphery of the lens, just having confidence in my chopper placement out into the capsular fornix and being immobilized the lens pieces. I'm removing the epinuclear material. The subincisional epinuclear material is a little bit stubborn. I'm using the chopper to lift some of that epinuclear material. And as I lift it, I'm able to mobilize the epinuclear material. I'm able to grab the anterior lip of the epinucleus, and it comes out fairly easily. I then push BSS as I pull the phaco tip out, and I'm going to switch the INA. I'm trying to maintain chamber stability as I switch instruments, and this just helps me feel better about keeping a fairly stable chamber and not allowing the eye to get completely flaccid. I place the INA handpiece in and activate irrigation and pull the BSS cannula out. I begin my cortical cleanup. In this case, there's not much cortex to be found. I switch to the polish mode and start polishing the anterior and posterior capsular surfaces. I can see a little bit of cortical materials in the subincisional area. You can see right there, there's some cortical material that's adherent to the posterior capsule, especially in the subincisional area. I'm using the polish mode with the INA handpiece to remove and loosen any attachments of this cortical material to the posterior capsule. As I begin to polish and remove and try to disassociate the cortical material from the capsular bag, this helps me in my subsequent steps when I do the capsule and cortical flushing technique with the BSS cannula. This helps me loosen and mobilize this cortical material in the subincisional space. And then I'm using the INA handpiece to help me remove the remainder of that cortical material. You can see there's quite a bit of cortical material that's liberated doing this technique. I prefer doing it this way because I don't really want to switch to different instruments to do bimanual, but I certainly acknowledge that bimanual would be a very easy way, an elegant way to get to this subincisional material. So after I do the cortical flush, I switch and I push the cohesive viscoelastic to inflate the capsular bag in the anterior chamber. I'm using the capsule sweep to sweep underneath the left side of the anterior capsule, but lo and behold, I'm able to pull out some of that subincisional cortical material. I sweep on the right side as well, liberating any cortical material and lens epithelial cells. I'm able to hold the lens with the sweep and then inject a single piece acrylic intraocular lens into the capsular bag. I go in with irrigation off and then inflate the eye and disengage each of the haptics away from the optic, turn the lens 90 degrees clockwise, and I tilt the lens so that I make sure that the optic is within the capsular fornix. By tilting the lens, I'm ensuring that both haptics are indeed in the bag, and by tilting the lens, I'm able to get to all the viscoelastic that's trapped underneath the lens. I then irrigate the viscoelastic from the anterior chamber, and then I'll hydrate my incisions. So this is a case that I did from start to finish, showing my standard cataract technique. I try to minimize any use of instruments that I don't need. I try to use the same instrument for multiple uses. So for example, I like to use a cannula to hold the eye rather than using forceps, or use the capsule sweep to hold the eye when I inject the IOL. So I try to minimize different uses of different instruments. I try to be as efficient as possible. There's absolutely no reason that you should be struggling with taking lenses out of small pupils, because as long as you can place the chopper out confidently within the capsular fornix and prolapsing the lens out of the bag, you should be able to handle these cases very easily. So I hope this was helpful to you. Please like and subscribe, and I thank you for your attention.